Welcome back. Up to now in the course, we've described the science of cancer as a disease, how it develops, what goes on inside the cancer cell in quite a bit of detail. And now let's turn back to the science behind cancer treatment. Recall in a previous lecture the story of Ellen, a 40-year-old woman who went and got tested for the BRCA1 breast cancer gene. Let's look at another example, unrelated to Ellen. We'll call her Susan. She also is worried about breast cancer. She's 66 years old. In a later lecture, I'm going to describe a mammogram. A mammogram is a low-dose X-ray used to detect possible breast cancer. Susan went for a mammogram and had a small lump detected in the mammogram, and the other breast was normal. The lump was biopsied, and it turned out to be a malignant breast cancer. She's older aged. She only has a single tumor, no family history. It's probably sporadic cancer, correct? It's probably not inherited cancer. Several weeks later, Susan had surgery to remove just the tumor region, and only the tumor region, and she was amazed. It conserved virtually all the rest of her breast, because an older friend of hers, Rita, who had breast cancer surgery 25 years previously, and in that case they removed all of the breast. Susan had a lumpectomy. Rita had a mastectomy. Breast cancer surgery clearly has changed recently. How has this happened? The answer is science over belief in medical practice. The origin of modern mastectomy is really from a surgeon named William Stewart Halsted, who lived over 100 years ago. He was born in New York in 1852 and trained as a physician at Columbia University and worked at New York Hospital. Halsted was a very talented surgeon and went to Europe and traveled in Europe learning all the latest techniques that they had there, and came back to America with two important ideas with surgery. And those ideas were anesthesia and antisepsis. First, anesthesia. Patients used to die of infection and of shock in surgery. They needed a reversible anesthetic that would put them to sleep so they wouldn't get shocked, die of shock. And the reversible anesthetic tried first was, in the modern era, was cocaine. Physicians would try that on them, and first they tried it on themselves and say, does it put me to sleep, etc. We ended up with a fair number of addicted physicians. It kind of worked, but then a dentist tried ether anesthesia, and ether was beautifully reversible. The drawing here shows ether anesthesia being invented in 1846. And it was first used on a neck tumor, a tumor of the neck, in that year, in 1846. Oliver Wendell Holmes Sr. was there, and he coined the term anesthesia. The word aesthesia refers to awareness and sensation, so anesthesia means less awareness and less sensation. That was the first advance that Halsted used. The second was antisepsis. Sepsis is an infection in the blood and in the body. And previously, physicians would use herbs, natural herbs in ancient times. But the problem with using herbs and herbal teas and stuff for antisepsis was that the dose wasn't controlled. You really didn't know what you were dealing with. Then they found alcohol worked really well. So they gave patients some brandy. Problem with that was some patients became toxic. It might kill them, or they'd end up with severe alcohol poisoning. An English physician named Joseph Lister, the name may be familiar to you, knew that bacteria cause diseases. He followed very avidly the work of Snow, the epidemiologist who worked on cholera, you remember. The bacterial model of disease was very current in the 19th century. Public health doctors in England used phenol, carbolic acid, on sewage water to treat it if it was dirty, and that killed the bacteria that were there. So Lister got the idea of using phenol around wounds and dressings on the battlefield, for example, and there were much less infections. So then they used it in then Halsted got the idea of using it in surgery around the surgical field, and there were much fewer infections. So that's the second advance. Really, a related advance was Halsted's nurse. she had a skin that was very sensitive to phenol, carbolic acid. And so she asked Halsted if she could use rubber gloves dipped in phenol. And Halsted, yeah, it's a great idea. So he put the three together: anesthetic, antisepsis, and gloves coated with antiseptic. And did the first operation using those three things. He removed the gallbladder of his mother. It was a sensation. The surgery was very successful. Now, when Halsted turned to breast cancer, he used a radical procedure. The radical procedure had been invented a couple of centuries previously in Europe. The idea was that if breast cancer spreads to lymph nodes, for example, it's spreading by growing directly to the lymph node. So the tumor might be localized and it might be growing directly to the lymph node. People didn't know much about the circulation. That is, a lymphatic vessel could drain at that point. So they were quite taken with the idea that the tumor kind of spreads by metastases, spreads by itself. So the only way to be sure you were getting all the tumor out was to remove the entire breast. It's called a radical mastectomy. Not just the primary site, but all the tissue, up to and including all the lymph nodes. And the presumption was this would prevent metastases. Halsted had a very strong personality. He was an extraordinary surgeon. And this led to very strong beliefs by him and by the people he trained and who then trained others. I've known surgeons who will point to me how their mentor was trained by someone who was trained by someone who was trained by Halsted. Everybody derives comes from Halsted. But is this really what happens? Does a tumor really grow all the way up to the metastases, to lymph nodes? And are the nodes on separate pathways than metastases? Well, that's what we found out. We found out all of these things, that the nodes were on separate pathways from metastases, and the tumor didn't grow out to it. So the idea was proposed, let's remove the tumor and the lymph nodes separately in small operations and spare removing the entire breast. Many surgeons were resistant to this idea. Well, they had been trained by descendants of Halsted, and that's the gold standard. And they didn't want to take the risk. They said, my God, if we don't, this is what we believe happens, and if we just remove a small piece, just the tumor area and maybe one or two lymph nodes, we're afraid, based on past experience maybe, that that's not the right way to do it, and the patient may get metastatic cancer. So a clinical trial was proposed. And the clinical trial was an experiment. They took a group of women with the same stage of tumor, breast cancer, and they were treated with either radical surgery, removing the whole breast and all lymph nodes, or lumpectomy. Okay? And they followed them over a period of years. And the result was, here is the result. This graph shows you percent survival over time. And actually, this is about 20 years ago. And survival is better now because they do other therapies as well as surgery. But there are two graphs here, but you can't tell them apart. One is for lumpectomy and the other is for mastectomy. You can't tell them apart. They're the same. Survival was the same. So the standard of care then changed over time from radical mastectomy to lumpectomy. Here's some graphics showing you the change. In 1983, almost all surgeries for breast cancer were radical mastectomies, and only about 10% were lumpectomies. By 2002, by the year 2000 essentially, it was 70% lumpectomies, 30% radical mastectomies. And the people doing radical mastectomies have a good reason for doing it with the condition of the patient and the tumor, etc. So surgeons changed over that period of time, right? And that's the surgery that Susan, our patient, got. So what the lesson in this is that science applied to surgery applies to surgery just as much as it applies to the rest of cancer, and also change comes gradually, contrary to beliefs. So in this lecture, I'm going to begin discussing cancer therapy, and I'll first discuss how treatments in general are curing cancer in some cases and prolonging survival in others. Then I'll talk about cancer treatments and how they're evaluated by clinical trials, a general introduction to all of cancer therapy. I'll proceed by then getting involved with surgery. I'll discuss surgical procedures that can prevent and diagnose cancer, and then surgery, which is the main treatment. So first, treatments can cure cancer or prolong survival. Before getting into specifics, let's just deal with the fact that there are 13 million people in America living with cancer, and by 2022, it's estimated there'll be 18 million people. If we look at survival rates for cancer in the last 10 or 20 years, you see that things are going well. This is data for England, and we're plotting percent survival in different cancers. And you see that if we compare 1971 and 2 to 2007, which is the latest data, you see that testicular cancer here, the 10-year survival went from 70% to close to 100%, doing really, really well. Unfortunately, for lung cancer, it's still about 5%. For esophageal cancer, it's quite low. For brain cancers, it's quite low. But you can see the curves are going up, right? And there's similar data for the US and Canada. One way to look at this is lives saved by improved therapies. So here is a graph showing the number of deaths, the mortality due to cancer overall, and the year of death beginning with 1975 and going to 2005. And we started about the 1990s and we go to 2005 or so. So we're going a 15-year period. And what this says is that for males, if the trend had continued that existed of increasing deaths due to cancer, because the population was going up, frankly, in the 1990s, if the trend had continued, many more people would die. In this case, it's about 500,000 people, in a cumulative sense, lives have been saved for males and 205,000 in females. So that's an optimistic spin on this. But let's bear in mind, 500,000 people every year in the United States are dying. So the aim of cancer treatment, maybe, would be to make it like AIDS. Okay? Cure is going to be difficult, but hopefully treatment will make cancer a chronic disease. A man or woman who gets AIDS now at age 25 in the United States or Europe will have a normal lifespan in years. That's a phenomenal statement, because AIDS was a death sentence in the past and still is in some countries that don't have access to therapy. AIDS is a lot easier in the sense that we know a lot about the virus and it's a single cause. But still, that may be our model for cancer, to turn it from a lethal disease into a chronic disease, an intermediary step to a cure. How are we going to extend survival? Well, let's look at the stage of cancer that's detected. This is something you've seen previously in the course, localized stage of colorectal cancer to highly metastatic on stage 4. And you see that probability of survival, this is Kaplan-Meier curve, after the cancer is removed in time. For stage 1, it's much better than in stage 4. So obviously, we want to design things that will be good to screen cancer earlier on. And in a later lecture, I will describe cancer screening. And you'll recall in the earlier that I described the mammogram, right? So mammograms are very good for getting breast cancer really early. There are 3 ways to treat cancer. And those 3 ways are surgery, radiation, and chemotherapy. If we can get the cancer really early, before it spreads, surgery, or sometimes radiation, can be curative. If the cancer has spread at diagnosis, which unfortunately is the case at least half the time at diagnosis, regional radiation can be used, or things that go in the blood, and the blood system takes drugs to every cell in the body, including where the cancer is hiding out. Chemotherapy have to be used. But as you've seen data, and as I mentioned before, a person with metastatic cancer, an adult, is rarely cured. How do we evaluate treatments? I want to talk a little bit about clinical trials. Legally, any doctor in this country of America can use any therapy. It's called an off-label use, as long as the doctor has reasonable ideas about it. However, in practice, doctors only use therapies that are scientifically proven, not something just off the wall. The key of therapy is to identify the patient for whom the treatment will work. That's called personalized medicine. And in cancer, we're going toward that at the molecular level. If we can get DNA mutations that we know happen in this patient and have targeted therapies just for that patient, medicine will be a lot better. Clinical trials prove the scientific merit of a new therapy. For example, a clinical trial was done on lumpectomy versus mastectomy in the breast. Now, how they did that, they took these women who had breast cancer and they randomly assigned them to one group or another with their consent. With their consent. And very often the researchers didn't know who was assigned when they analyzed the data. And then they come to the endpoint. Now, what was the endpoint in the clinical trial I described to you? Survival. Remember, that was on the y-axis. Another endpoint might be, if we're looking at a drug that's going to prolong life, disease progression, which means disease comes back. So the tumor, we're looking at the tumor and we're stopping it from growing and it's keeping in one place. And then we watch over a period of months and see how long does it take if a patient is being treated with this drug for the tumor to come back, to start what they call progressing. Response, that might be another criterion. A responsive tumor might be how much has the tumor shrunk. And there are criteria, quantitative criteria, by which physicians will measure tumor shrinkage and response. So we can look at mortality, we can look at progression, we can look at response. The groups we do in comparison, right? The groups have to be equal in every way. That's quite difficult. Patients have to have informed consent. By informed consent, I mean the patient knows why they're participating in this trial, what the potential results could be, but also what the potential drawbacks or side effects could be of this experimental therapy. It's hard to do informed consent well. For any of you who've been in the hospital lately, and in a teaching hospital, etc., they give you these 15 pages to sign, and you initial here, and you initial there. It's like renting a car, only the stakes are a lot higher. You really don't know what you're reading very often. That's being improved, hopefully. Typically, clinical trials begin after preclinical research. I do preclinical research. I work on cells and biopsies. I design therapies, etc. I work on small cell lung cancer and design therapies and then get them into animals and do animal studies and then hand them off to the physician saying, okay, maybe it's ready for a clinical trial in humans. Clinical trials are typically done in 3 phases, phase 1, 2, and 3. Phase 1 typically has 20 to 80 patients, and we're looking for safety and side effects of the drug. And typically these are patients with the advanced cancer, the target cancer, for whom other treatments have failed. So really you're not looking for a cure here, you're looking for the maximum tolerated dose, and you're looking maybe to see if it's working a little bit. What you try to do is equalize just look at the group of people. So here's the characteristics of people on a phase 1 trial for colon cancer. The average age is 58. 13 of them of 58 of the 21 were males. Their health status is gated. The stage of the tumor is there. Previous treatment, stage of disease, local metastatic, etc. So you have to report on who these people were. If a drug passes phase 1 and it's not toxic and it looks like it's doing some good, you might go to phase 2. And in phase 2, we have 100 to 300 patients with a specific cancer who may or may not have been treated. This may be the first treatment, and we're looking for effectiveness. Phase 3 is the large one of several thousand patients, control and experimental groups who we hope are equal in every way except treatment by this medication or radiation or whatever. And we're looking here now for side effects as well as effectiveness. So here's 2 groups comparing drug A and B, an actual phase 3 trial for lung cancer. Average ages are about the same. Sex is about the same. Sex ratio is the same. The health status is the same. Smoking history is about the same. See, we're trying to equalize them. The type of cancer they have is the same, squamous cell, and the local metastatic ratio is about the same. So now we treat the drug A and drug B, and we do a comparison. Or drug B might be a different or no treatment at all. The real comparison now, we look, this is the gold standard. The real comparison after a phase 3 characteristics is the treatment better than current treatment? Now, very often you'll see results of a phase 3 trial expressed as compared to placebo. That's a control that got a pill that doesn't have the drug. But that's really not that meaningful in the sense that I want to know whether the current treatment is this thing, how much better than the current treatment this is. Because very often the new drugs or new treatments are extremely expensive and they might have equally bad side effects. There's a long road to therapy. a long road. It starts with basic research, and then it goes to preclinical and clinical development, FDA filing. There's hundreds of places for decisions, et cetera. The cost of that breast cancer, in current dollars, that breast cancer lumpectomy, mastectomy, about $200 million. Drug companies say about $800 million. They fold it into the price of drugs. Other people say it's less, it's $250. It's quite a long road in most countries. Go back to surgery. Let's talk a little bit about surgical procedures that can prevent or diagnose cancer. We can actually prevent cancer from happening if we know the person might get cancer by removing the cells that could be cancerous. Right? It's going to decrease the probability. So we'd have medical conditions or genetic conditions that predispose people to cancer. So for example, an undescended testis that's at a higher temperature because it's in the body, is more prone to testicular cancer. So what does a physician do? Somewhat after birth, maybe a year after birth, they do a simple operation to put the testis back into the scrotum. People who have the BRCA1 mutation, I mentioned before, right? It's expressed in cancers, could be breast and ovarian, so they will do removal of both breasts. Inherited colon cancer, they will essentially remove the colon in a young person. Here's an example of a clinical trial on this, clinical data. The question was, does bilateral mastectomy, removing the entire breast for a carrier of the BRCA1 mutation, who has an 80% chance of getting breast cancer, prevent subsequent breast cancer? And so we have a Kaplan-Meier type curve, proportion without breast cancer over time after surgery in years. We're going up to 30 years now. And we're assuming these people had BRCA1 in a couple of cases. The people who had the operation had virtually no breast cancer because there are no breast cells. And the people who have none, of course, 80% of them get breast cancer. So that's pretty graphic data for a person in that situation to be faced with. Cancer is diagnosed over 90% of the time by surgery. And there's a bunch of ways to do this. You can take a needle or a tube if in the lung, if cancer of the lung, like the tumor I work on, the cells will be floating sometime in fluid of the lung, as I mentioned. You just take a syringe and just draw out some of the fluid, etc. The tissue is broken up. It's hard to get intact groups of cells, but you can do it. Another way to do get tissue for surgically for diagnosis is to do a needle biopsy. This is a needle biopsy of metastasis in the lung. You see the needle sticking in right to the metastasis. You get a core metastasis. You get a core of tissue. You can guide it and then look at it. The third method is incisional biopsy. Just take a scalpel, remove a piece of the tumor for diagnosis. This is very often done during surgery, where they're diagnosing. They open up the patient surgically. They see a big tumor there. They take a piece out. They send it downstairs to the pathologist, who then looks at it right away and makes a diagnosis, and then they can decide whether to remove the rest of the tumor at that time or not. Finally, excisional biopsy. They remove the whole tumor and then diagnose it that way. That's typically of moles in the skin, etc. So this is how you do surgery to prevent or diagnose cancer. Now, what about treatment of cancer? 60% of cancer is treated, at least, by surgery at some point. And the key to treatment is localization and the absence of metastasis, because if the tumor is treated at a localized stage and there is no metastasis present, it can be curative. Now, there are pros and cons to surgery. Here they are. The pros are there is no resistance. There is no biological resistance to surgery. You're going to see later on in the course that in chemotherapy, tumors can become resistant. Surgery, no resistance. You just cut it out. Surgery has no side effects that cause cancer. If you treat a patient with radiation or chemotherapy, very often you're damaging DNA. They could get not with surgery. Tumors could be heterogeneous, different targets, right? There might be 15 targets. Surgeon doesn't care. Take the whole thing out. No problem. And of course, you can get a total cure if it's localized. However, there are disadvantages to surgery. The disadvantages are it's not specific. So if a tumor is in the body, if it's just hanging out in a nice open place, that's nice. But if it's in an organ, you're going to remove normal as well as tumor tissues. Think of that happening in the brain, for example. And you could have a loss of function of the organ. And of course, surgery is not as useful if the tumor has spread and metastatic at the time of diagnosis. It can be useful because you're removing a tumor burden, and you recall previous lecture that tumors produce molecules that lead to a bad state of the body. And so if we reduce the tumor burden by taking the tumor out, sometimes it will reduce the bad effects of the tumor on the patient. However, as we found out with Folkman, Judah Folkman's work, removing the tumor, sometimes the metastases will take off because the tumor is inhibiting angiogenesis. There are many surgical procedures for cancer. It's a highly specialized field with amazingly talented women and men who do this work. There's a trend, as we've known, to smaller surgeries that are not as disfiguring and minimizing incisions. You probably heard about the robot. There are robotics now. People are doing robot surgeries where the doctor sits by a computer console and manipulates the robot to do the surgery. This is extremely fine surgery. The advantage of the robot is usually to reduce hospital stay. It's a smaller incision very often in some surgeries. It reduces blood loss if they're very careful in doing it. Question is, does the robot improve survival? Wherever you are in America, you will see billboards saying, we do robotic surgery, come to our clinic, etc. But very seldom will you see on a claim that people get better. In other words, that the survival rate is improved. And the data are not really in for most types of cancer robotic surgery that it's an advantage in terms of survival. It is more expensive. The robots cost a lot of money. So it's a cost-benefit analysis here of whether to use that. Question of whether to do surgery when cancer is found is sometimes a very difficult one. If a small tumor like a prostate cancer is found, for example, and it is a prostate cancer, it's in the prostate cancer may be an indolent or a slow-growing tumor. And so if it grows slow, big deal. You'll probably die of something else before you die of prostate cancer. The problem is we don't know which tumors sometimes are the ones that are rapidly growing and slow growing. Perhaps as time goes on, molecular signatures will help, as they did for breast cancer. Remember this gene expression signature to stratify patients who might be needing surgery. Removal of lymph nodes, surgical treatment removing lymph nodes. Lymph nodes are places where tumor cells can be drained from a tissue into a lymphatic, and the lymph node is kind of a traffic circle where a lymph node cells will be. And some tumor cells may be in there, and they return, of course, to the circulation, to the heart, and that's how metastasis can happen. It's one of the roots of metastasis. So the problem is, what lymph nodes do you remove? The problem, if you remove lymph nodes, the problem is you're removing that tube system. So for example, if I have tubes in my arm that are taking fluid that accumulates in my arm, and it goes into my shoulder and my armpit and goes back to the heart eventually, and if I cut one, if I take a lymph node out and I'm doing surgery and the tube seals up, we can get accumulation of fluid in my arm for the rest of my life. That's called lymphedema. Edema is swelling, lymphedema, and swollen tissues. And this is a pretty typical hazard of people who have cancer sometimes because they essentially are missing lymph node drainage. It's a very, unfortunately, a rather common side effect where lymph nodes are removed. Now, one of the ways that kind of makes sense is, well, why don't you look at how the tumor drains out into lymph nodes before removing them, and just remove the first lymph node. So you take the tumor here, and you look at the drainage, and you say, let's look at the first lymph node and see if it's got cancer. And if it does have cancer, we'll remove a bunch of the others. And if it doesn't have cancer, we'll just remove that one. So this kind of makes sense. So here's the sentinel lymph node, and we won't remove the rest. And this has been standard procedure in a lot of tumors. But the question is, let's look at overall survival. Does it improve overall survival? And recently this was examined in a long-term clinical study. And the answer is no difference. Survival percent over years, and this was breast cancer, people who sentinel node, only the one node was removed, and in this found cancer. And here all the nodes were removed, and it didn't matter if you removed all the nodes or not. So it's unexpected, but here's the problem. In the women who had all those nodes removed, they have very bad lymphedema now. So again, surgery beliefs will yield to changes in practice as science is done. In this lecture, I've begun to discuss the science behind cancer therapy. I gave you a general discussion of treatments that can cure cancer and prolong survival, and we talked a little bit about clinical trials to evaluate treatments. Then I talked about surgery that can either prevent and diagnose cancer, and finally how surgical treatment proceeds with a couple of examples. Surgery is used for a lot of cancers, but some are treated instead or in addition with radiation. And that's the subject of the next lecture. Thank you.